It's an honor to welcome Dr. Preetha Reddy, a distinguished leader in healthcare innovation. As Vice Chairperson of Apollo Hospitals, one of the India's largest healthcare conglomerates, Dr. Reddy has driven transformative growth, significantly enhancing hospital capacity in one of the most populated countries in the world. Her outstanding leadership has been recognized with prestigious awards, including ET Businesswoman of the Year and Healthcare Personality of the Year. Today, Dr. Reddy will speak on essential and timely topic, rewriting the clinical playbook, Where Are the Women? Addressing inclusivity and empowerment in healthcare. I would like everyone to join me in warmly welcoming Dr. Preetha Reddy.
Thank you. I'm honored and delighted to be here at Oxford with all of you, especially a welcome to a former minister from Telangana, Mr. Somnath, who really set India on the global map, friends from CII, and of course, Siddharth, the faculty at Oxford, the dean, and really the young students, global citizens of tomorrow. I'm honored to be here, and Siddharth, thank you. Where are you? Thank you for the invitation. Thank you. It's when I was asked to speak about rewriting a clinical playbook, I was really happy to do that, and especially after going after Professor Sen, he kind of set the tone. Because that's really what healthcare of the future is going to be about, and hospitals of the future. So that works really well. But where are the women? And it's been said, we all know, that women really hold up half the sky. There are more men in the gathering, I guess. But this is a point which all of us have to see and understand, that we really are half the population. Our genetic makeup is so different. And we do hold up half the sky in multiple formats, in different ways. And there's a very famous saying, actually, and there is a book. So at some point, the book it's called Half the Sky. And I'd love for all of you to read it because it's really quite interesting. It's not a human story. But in healthcare and the way healthcare is delivered, and maybe in many other aspects, the women were never default as a patient. It was, yes, we will do. And for women, it was mainly about the reproductive system and some others, if required. Even if it was cancer, it was, breast and gynec cancer, and maybe others. So I think this is what happened in the healthcare field, and no fault of anybody, because in 1977 to 1993, the US FDA, they actively discouraged participation of women of the childbearing age. And that was because, there were huge mishaps with some of the drugs which they were using. And so they pulled out and they said, okay, in all the clinical trials, we will not have women. But this had its repercussions, and it left a stark imprint, because now women and all the drugs which are produced, which are resulted, clinical pathways, don't take into active cognizance the fact that, women have to be part of a study. And again, a lot of the drugs, a lot of the procedures, a lot of the implants, everything is really centered around the Caucasian male. But that's because research and innovation is, something which has happened in the Western world. But if you take that down and you say that not even 50% of women are part of these studies, and then you go back and say that the Asian women as a population, then they are coming down to almost 17%. So if you use a drug, even for cholesterol or cancer interventions, cardiac interventions, so on and so forth, Asian women really represent 17% of drug interventions and drug studies. And that is why we say that when we want to really look at the future, look at the young women of the future, let us see that when there are interventions, when there are drugs, it really targets the right audience, the right way, with the right outcomes. So there are four aspects to look at. One, of course, is awareness. So let's be aware of the plan, of the issue, of the fact that, a lot of things, the clinical interventions are really not targeted, not designed completely for women. Provide access for research for women to have equitable healthcare wherever, in many parts of the world, African countries, Asian countries, even in the Western world. I think we have to think of ways of access. They should not be waiting in the ER the way they are. And this is a problem all over the world. I was trying to see and understand, I said, which are the countries which really give fantastic healthcare to their people? And these were the European countries: Norway, Sweden, Denmark, to some extent Germany. That's it. And then Singapore. So, we're saying that we're taking smaller countries, giving great healthcare to people, but what about the large populations? And in that, what about the women? So I think this is where focus, government policy, things which have to be done. And so we have to find ways to provide access, make them more inclusive, and look at interventions which are timely. Because the leading cause of death, which has not been registered, has come out in a study which was called the Virgo study. And the Virgo study really spoke about variations in recovery and the role of gender on outcomes. This was a famous study globally. And it said that, when women come into the ER, they come with a stomach ache, they come with a chest pain, and the clinical pathways don't really focus on an acute disease or an acute episode. And that is why this focus on women in this Virgo study became very famous. There was another example from oncology where when you give chemo drugs, the body has to clear it. And the drug, when it is targeted therapies or given, the women don't clear it as fast as the male system, which means that you've got these toxic chemo drugs in the bodies because they've not been designed for the female body. So this is what we have on hand. But having said that, I think the future is bright. And hospitals of the future will target the fact that, now we have molecular biology, we have genomic studies. The UK is doing this huge program on collecting genomic data. Every person living in the UK, a UK citizen, gets their whole genome, like the Janpatrika, the way we say it in India, gets that mapped and gets that designed. Now, what this throws up is a whole host of data. So the way healthcare is going to be delivered in the future, your clinical playbook is going to be so different because your genomes would have been mapped. And since we're all going digital in many ways, and for that, I'm very proud of the way our country has done it. I'm a very proud Indian. I actually usually wear a sari all the time. For some reason, I didn't. But having said that, India has a National Health Digital Mission, which the government has started. We have started Ayushman Bharat. It's a daring program, and that really gives access to every Indian for good and high standards of healthcare which are being monitored. Gone are the days where you can sit in a forum and say, oh, this is not happening. Indians are not getting the best healthcare. Today, you can proudly say that Indians have access to the best healthcare. We understand about insurance. Insurance is available in multiple states. So these are things which are happening real time. So the clinical playbook in large geographies, large populations, is actually being rewritten. And here, if we can be cognizant of the fact that women, are a large population, I think it will be a job. You can never say a job well done in healthcare, by the way, but I think we will be on the right track. And I think that's really what we're looking for. Another very ambitious and global program is that we want to democratize the way molecular biology is being done, the genomic analysis is being done, because today, if you need to do it, it's expensive. It's about $4,000. It can give or take a little bit less. But we can do that. You can then say that anyone coming for targeted therapies, anyone coming for diseases which we're not very sure about, everybody going through some kind of a preventive health program, male or female, you can get their genomic analysis. Once you do that, you will actually be able to see that the women have to be targeted, they have to be handled in a different way. History taking in hospitals has to be different. So the whole scenario changes, and it will all be targeted towards the way that, this is a genomic makeup and this is the way it will be done. And then the drug companies come in, those making high-end chemo drugs, those making cardiac drugs, even stents. All stents are standardized, size 1 to whatever. It's got XYZ. Every company has fancy names for their stents. It's there. But just imagine that if these stents can actually be tailored better for women's arteries. If your knees, which, you're getting, women, by the way, especially in India and especially in certain states, which I will not mention, are targets for knee replacements. This is the way it is. But if that can be designed, you can use AI now, you can do 3D mapping and really design the joints in such a way that they work for women and it's not one size fits all. I think we would have made some changes. So I think the future is exciting. And the fact is that, we're using AI in multiple formats. The machines are helping us. And I will not agree to the fact that a machine can completely tell you how to deliver healthcare. It will guide you in the right format. It will tell you where you need to. It will help where we don't have enough healthcare workers. But the machine will lead you in the right direction, that if a healthcare worker, whether it's a doctor, a nurse, triage someone, it's taking you an hour to do something, you could probably do it in 5 or 10 minutes because the machine is going to, take you in the right direction. Then comes precision medicine. And all this, as I'm standing and I'm talking to all of you, is real. It's been validated. There have been pilots, and it's available to do. But the thing is, we have to start adopting it. We have to see how can we make it accessible to our population. And I think that is a responsibility of healthcare providers. And as a country, we have fantastic leadership in the government who really supports progress in all the governments in multiple states. We also have a large pool of professionals. When my dad started the Apollo hospitals, it was like we will fight brain drain because doctors from India were going off to the US and UK, and we would go every few months and try and get them to move back. But today, the homegrown clinicians, the nurses from India, the technicians, the researchers, the scientists are so good that we really don't have to, worry about going somewhere to recruit them. So I think things are changing in our country, and we should be able to, bring out products, talk about research, which will really impact the rest of the globe. So thank you so much for the invitation. I'm happy to take questions, but I would like to tell you that, going forward, there will not be a divide, and that in a system, in a healthcare system, medicine will be delivered. It will be precision medicine. It will be targeted towards the genomic makeup, and we will be able to monitor outcomes which are so much better than what it was, because that is our responsibility for future generations. So thank you very much for your attention. I'm happy to take questions if there's time. Yes, of course.
Thanks for such a wonderful talk. I think it's extremely inspiring for all of us women at the business school to see someone like you here. So, ma'am, I want to ask if there's a new study about how women need more sleep than men. This is very recent. This is rather new that women now need 9 hours of sleep compared to the average that has been given earlier. So I think sleep has a lot to do with mental health, for example, which is also quite a big conversation that takes place. In your hypothesis, how much do you think mental health matters, and do you have a plan for how we include women in the mental health conversation as well?
So about sleep, honestly, I can't answer that because I didn't read a study. But if we get good sound sleep, even 6 hours, I think it's fantastic. I'm not so sure we're all getting 6 hours of sound and deep sleep. So having said that, I'm not sure on that question. But mental health is globally a large issue. It's been, it's blown up after COVID, because we've seen the effect of what something like that, whether it's loneliness, whether it's fear, whether it's loss, what it has done to people. And it definitely is an issue. There are multiple formats happening in the mental health space. I'm not sure if, women need it more than men. But I think women have to be acknowledged. The problem here is that they don't get acknowledged enough. And sometimes, there's a societal impact, so it's kind of hidden. They probably don't have anyone to talk to. And sometimes women are putting up a front. So all these things happen. But to answer your question, mental health is a huge problem. What we are doing towards mental health is the tip of the iceberg. And I am not sure if really, all the answers are the right ones either, because, just because we have social media and we have all that, and there's so many products coming up, we don't know. Research will have to tell us if it's the right one. But I think just adopting a few of lifestyle changes is a good thing to do. Any religion does not matter, but being philosophical about things matters. So this is my take on it. There are only women asking questions. Yeah. Okay. I'll switch back to you guys.
Dr. Reddy, thank you so much for your time. I guess I would be curious to know your perspective on what the biggest challenges for the Indian healthcare system in the next 5 to 10 years, and how Apollo is positioned to kind of address that.
Well, you can take hours on it, but I'll do it really quickly. Indian healthcare, it's evolved. It's reaching, if we have 1.4 billion people, more than half are covered in some way or the other, which I can rightfully say. In terms of challenges, we still have, we need adequate capital. Whether it's the private sector or the public sector, both need capital allocation for health. And it needs to be done. We're grappling with, putting money aside for our defense budgets. I'm not saying we should not, but the epidemic of some disease burden might be much larger than, really having a whole armory to fight, the problems which we do have. So having said that, I think our access to capital is important, and we have to find answers for that. We have to build infrastructure in the remote locations. We have to adopt digital more, because we as a provider do telemedicine services in remote locations, high up in the mountains where it's inaccessible, so you can save lives. We do it in some of the African countries. So technology is a huge answer, adoption of technology. But globally and in India, as a challenge, is the lack of adequate manpower. We do not have enough doctors, nurses, allied healthcare workers, technicians, and God bless the nurses. The moment they work for some time, they're going off abroad. So they get absorbed in other countries. So I think we as a country, we need policy, we need empowerment for our healthcare workers, acknowledgement for our healthcare workers. So I think it's infra, capital, and skills, adequate skill manpower.
Thank you.
Sure, go ahead.
Hi, my name is Edwin. I'm a doctor from Singapore. This is a topic that we
Sure, you will. Do you want to give her a mic?
Oh, I can just speak louder.
Okay.
So my name is Edwin. I'm a doctor from Singapore. And so this topic is really interesting to me. I kind of have 2 questions. But the first thing is, Apollo is like a private hospital. And I think there's a lot of discussion about how private hospitals are profit-driven. And I was wondering for Apollo, how do you kind of balance the need for profit with accessible healthcare? And then the second question I have is, Apollo is like the largest healthcare group in India. And I was curious, that seems to me that you have a lot of power in terms of rewriting the clinical playbook. So what kind of programs does Apollo that to rewrite the clinical playbook program?
So in terms of profit or whatever, we all have shareholder responsibility returns. There is no free cash when you're in the private sector, unless there is charity, which again is there, and those hospitals are doing very well. So I think a decent return on investment, on equity, return to the shareholders is important. So hospitals have to do it judicially. You have to do what you have to do. And then there's a price for quality. Even now, 80% of our consumables are imported. We're still importing stents and knee joints and so on and so forth. The devices are imported. Still equipment is imported. There's a duty on that. So I think there's a cost to quality healthcare, which we're really trying to do. What was the second part of your question?
So Apollo like the largest.
What are the programs we're doing? Is it to reach out to people? So basically, our philosophy now is that you can build so many hospital beds and they will get filled up some way or the other. The thing is, you have to keep people healthy, because the economic impact on ill health is huge. There's a country impact, government impact. There's a family impact, because one family member falls ill, so much of resources have to go towards it. So I think keeping people well, picking up disease early, fighting the onset of NCDs. Now, of course, there's obesity and mental health, and all that has been added to the list. I think keeping people well is our biggest objective, and that is why now we run the largest screening program in maybe one of the world's largest. I don't have the numbers, but we screen about almost 4 million plus, upwards of 4 million people every year. Different formats of screening, so that there's an awareness about keeping well. Okay, that's probably your last question.
My name is Manjiri Gokhale Joshi. It's going to be 140 years since India's first woman doctor received her medical degree in a 9-year study. And inside business school where we're seated, we just crossed the 50% mark on the number of women in an MBA class just 2 years ago. Even today, in the senior degrees offered here, when it comes to the executive MBAs and all the senior degrees, it's a big struggle to get within professions at the high level. My question is, someone like you who is one of the country's, I would say, leading leaders in the area of medicine, when is it that we're not going to have a topic related to women and why they're not there? Do you think it's going to happen in this lifetime?
Why do you think I said, even when I started, that I'm not fighting for, women's rights and things like that? It has to happen naturally. There is a yin and there is a yang, and we have to recognize that. And hopefully a time will come where there is no gender bias. You just have to be good at what you do, and you have to contribute, because we're capable of contributing as well. And this whole thing about family and, you have to do this, everybody has to do what they have to do. So I'm hoping it's gotten much better. We cannot complain. We run 2 medical schools, and I know that there are more women, doctors graduating from there. So hopefully it'll happen. Are we done? Yeah.
First of all, thank you so much for this conversation. And there are 2 points that you picked up in your conversation. One was how medical science either relegates women to the periphery, or there's a tokenistic representation of specifically brown women in policy. And you also mentioned Sweden in your presentation. I worked in Sweden, and from my own experience, access to healthcare in India is far more refined than what happens in the global north countries. And this is not just because it's private healthcare, but the empathy that the Indian doctors have, unfortunately, it becomes a little more surrogate when we talk about global north countries, and it's more in global south countries. But in your experience, while we do have access to resources and capital, I personally think that the quantifiable of agency misses as far as that access is concerned. Sometimes women do not want to access SRHR, or there is some kind of roadblocks in their experience. In your prolific experience, where I'm sure you work both with the grassroots and with the prolific industry, what can the medical science do to make sure that there is an active agency that is also practiced amongst women?
So one is, I'm surprised you said that about Sweden, which means we're doing something very well in our country. We just have to communicate it to the rest of the world, which is fantastic. The second is, just to provide social access for women to know. We just did it because we're passionate about healthcare, is that for the first time we've set up a dedicated women's hospital in Delhi. It's small, it's boutique, but it's only for women, and it's mainly for cancer. And then all the other rare diseases will follow. It's only because then they know that there is something designed specially for them. It's more about the awareness. And I think once more people do things like this, then the women will know that they have a chance, they have an access. Rural women, the only thing we can do is go and talk to them. You know, we run camps, we run screening, we do whatever we can. But to me, it's a long road ahead and there's a lot of work to be done. Thank you.